So, hello everyone. As you know now, my name is Lorenzo Gordon. I'm director and co-founder of Tech in Care. Just to, well, as Sean's already said, I'm here to talk to you about our case study regarding enabling patient flow from hospital to community regarding discharge to assess, and more recently back again from community into hospital. Just a bit of background that Tech in Care is a relatively new company. It started at the beginning of 2021. It's the coming together of two very well established and long serving companies, my own, which is Maldaba, which is a London based software development agency and a co-funding platform for the public sector CC2I. As Sean said, I've allowed time at the end for questions, so I'll be happy to answer any questions you may have then. The story really begins with the NHS Digital and the Local Government Association Social Care Digital Innovation Accelerator, a bit of a mouthful, that ran from 2020 to 2021. And as part of that accelerator program, NHS Digital and the LGA spoke to local authorities up and down the country to understand what were the biggest challenges facing them. This was during the first lockdown. Overwhelmingly, one of the issues facing local authorities was the discharge to assess care pathway, which I'm sure you're all familiar with, but in case you're not, discharge to assess is the care pathway when you are admitted to hospital and you're on an acute ward and you're identified as being vulnerable and needing additional support from the local authority to enable the safe discharge back into a community setting. The challenges that were being faced by local authorities and their NHS partners, broadly speaking, were around communications. So again, you may well be aware, but on the one hand, you have NHS trusts with their electronic patient records that largely are inaccessible to local authorities. And on the other hand, you have local authorities with their adult social care systems that largely are inaccessible to NHS trusts. So you have two silos of data and people using each one who can't access the other. The result of that, again, you may well be familiar, is many phone calls during the course of a day, various spreadsheets being updated and exchanged, or images of spreadsheets, and the constant battle by staff in both organisations to try and correlate and coordinate the information that they both have in order to ensure the safe discharge. And the risks of that scenario mean that there are slow discharges, there are poor quality experiences for people, and there are risks of people being discharged without the proper care package in place, or preventing the discharge happen because they haven't got the care package in place, and then the assessment not taking place in the community at the time and location that it is supposed to. So my company Maldaba was chosen as the software delivery partner for this project, and we had 7 months to work with 5 local authorities plus their NHS Trust partners, as well as other partners involved in D2A, such as transport and independent care providers. And during those 7 months, we had to make sure that we had gone through a co-design to articulate the problem and document the requirements. We had to design, prototype, develop, build and launch a solution to this problem. And we also had to cover off the IG side so that when the solution was delivered, it was acceptable both from an NHS and local authority point of view, that from an IG perspective, that it was safe to use. And you won't be surprised to hear that we did this. And the result is hospital to home. So hospital to home is a system agnostic cloud service that provides a single version of the truth for local authorities and NHS trusts and all other delivery partners to access anytime securely in real time. So the users are all of the agencies that I was talking about before, plus more. The exact configuration will depend on the locality where we're setting it up. And information is updated in real time, so that, for example, if ward staff add a new D2A referral onto the system, immediately that is shown up for local authority staff on their dashboards and also on their workloads, and they can see the updates in real time in the individual case histories. Similarly, if local authority staff are updating a case, for example, to say that the care package is now in place and they're ready to receive that individual, the ward staff will receive that information immediately. So suddenly they have gone from a position where, as I was saying, the information was siloed and the information wasn't flowing. And it's a cruel irony that because the information wasn't flowing, people weren't flowing from hospital back into the community, that then enabled everybody to see the information in real time, really simply, really easily, and enable those efficient, safe and effective discharges to take place. The benefits of that, as I've said, are that you have a single version of the truth. So we move away from the he said, she said arguments between different organizations about who knew what when. It's really easy to see very clear communication of which person did which activity when, and there's a full history for every case, for every person, all the time, that can be accessed by all the stakeholders who are involved. The result of that is that the speed of discharge is improved, and the result of that, the impact of that, is that you then start to release bed availability within the acutes. And that communication isn't just within the system, so it's not just reliant on people logging in and accessing the system from their phones or from their laptops, but also it's proactive, so that individual users or teams can be notified by email or SMS as a person is progressed along the D2A pathway. And that's beneficial because it's not relying on them being reactive and coming into the system. It can notify them without them even being asked to check. The impacts that we've seen so far in the 18 months or so that the system's been live is significant reduction in admin overhead for local authority and NHS frontline staff, as well as on average 1 bed night being saved for every 2 D2As that are passing through the system. There are more details of this on the Hospital to Home website. There's a fuller business case which you're welcome to explore, and obviously you're welcome to get in touch, and we're very happy to provide more details from where these figures have come from. Moving on from discharge to assess, we were fortunate to secure some UKRI funding, and we're building a second module into the system, and this is where the flow back again comes in. So we're now starting to focus on intermediate care, and a version of this module will be going live early in 2023, so kind of January, February time. And this module is focused on the 4 models of care, so reablement, home-based, bed-based and crisis. And it's taking the same principles of being very data light, process-focused case management system that covers all of those 4 models of care. And just as D2A was looking at getting people safely and securely out of hospitals back into the community, the IC module is looking at both step-up care, where hopefully we can prevent or at least delay admission into hospital, and the exchange of that information between the various agencies on the ground in community to enable that to happen, and also step down care, so that when people are discharged through D2A, they can then be transferred into the intermediate care module and be cared for through the community. That broader vision then allows also a broader level of understanding for staff. So for example, when you have the case of step-up care where someone is going from community into hospital, those hospitals will be able to access the information, if appropriate, of the intermediate care handling, so that they can understand what's gone before. Similarly, when they're going from D2A into IC, where appropriate, that information can be transferred so that the D2A information from the hospital can be going to the IC teams to better inform them on how they support people while they're being cared for in the community. The IC module will also kind of add some crucial new features into the system, such as the ability to handle waiting lists across services. So for example, we know that someone may be being supported in bed-based and they're being referred to the home-based service. So that referral can take place within intermediate care, and also where the home-based, for example, in that instance don't have capacity, they can go onto the waiting list and that can be tracked and everyone can understand what's going on, and that will support managers in understanding where the allocation is and where the need is in order to direct capacity. The other piece of work that we're currently undergoing, again with the UKRI funding, is really looking to address as holistically as possible the issue of interoperability, which is a big issue for everybody involved in digital health right now. One of the reasons that we focused hospital to home to be a really minimal data set is to avoid asking people manually to enter information that may be on other systems. And we know that by introducing yet another system, the risk is that we become the straw that breaks the camel's back in terms of the amount of systems that staff are being asked to engage with and work with on a daily basis. And obviously we want to avoid that. So we're already working with a number of local authorities and NHS trusts, whether they're using bespoke systems, both on the EPR side, on the NHS trust side, or the ASC, if the local authority side, as well as with established third-party providers, such as those you can see on the slide here. We're using best practice standards, such as HL7 FHIR, and what we're looking to do is address interoperability in a bi-directional manner. So there is a lot of work going on around this generally, but often it is in a unidirectional manner. So it's taking it from these systems into a shared space where everybody can read but not update the information. What we're looking to do is make that bi-directional, so that, for example, on the wards where people are using their EPRs, if they identify someone as being on the D2A pathway in their EPR, that will automatically trigger a referral going into hospital to home. Now that's great at one level, because that means that without the ward staff having to do anything, the local authority staff logging into hospital to home can see that information. But we're trying to go further as well, so that hospital to home can push that information into the adult social care systems like Mosaic or Liquid Logic, so that they don't even need to log into hospital to home to see that. So that whilst we have the interface that everyone will still be able to access, in this instance we would be acting almost as a middle layer, facilitating communication between those two systems and back in the other direction, such as the example I gave before, where the local authority notifies that the care package is in place. That can automatically trigger an API response into hospital to home. Well, that's great. But then that can trigger a further API response to go back into the EPR, so that the ward staff don't even need to access hospital to home. The UKRI funding also presents us with quite a wonderful opportunity that we're happy to share with you right now, which is that if you're not already a hospital to home user or customer who we're already working with on interoperability, there's the opportunity, there are 3 spaces for organisations who are engaged in interoperability challenges and want to talk to us about how we might be able to support your work in this. To get in touch, either via the Convensis platform, or you can see my email is in the slide here, to contact me. It is first come, first serve, so I'd encourage anyone who's interested to get in touch as soon as possible. And we're really kind of excited and happy to work with other organisations to see how far we can go to address challenges that we all face when it comes to interoperability. I'm going to finish my presentation here and then hand over for any questions.
Hi, Lorenzo, can you hear me okay?
Yeah, I can.
Oh, sorry about that. I just away with the fairies there for a minute. Thank you for the presentation. Absolutely brilliant stuff. Poll is on screen now for all the attendees. And while that poll is being run, I'm just going to start off with a quick question here. So bearing in mind shift work for staff in LA's and trusts, can the notifications be sent to a ward, a staffing group directly?
Yes is the short answer. So they can be sent to whole teams as well as to individual people. I'd probably need to kind of get into the conversation with the person who asked that question in a little bit more detail, but the short answer is yes.
Yeah, well, what I was going to suggest as well, there's a few people that have identified too many questions to ask on here, Nadine Mooney being one of them, and Unanti. So what we'll do is I will get, well, I'll link you up with Nadine post-conference anyway. She said she's got multiple questions to ask. Unanti, I would recommend doing the same thing. So either access further information on Lorenzo and his team by the handouts PDF, or by all means, just drop me an email and I'll link you up directly. And just got a message through here now for Sarah. This is exactly what we are trying to achieve with our LAS. Just emailed you now, so you should have an email in your inbox already from Sarah. So Lorenzo, it seems like there's a lot of interest there built up. Amazing little service, and hopefully we can be used as a conduit to kind of keep sharing that information for you as we go forward. And as mentioned, the in-person meetings taking place next year, and that's always a good occasion. So hopefully see you there, sir.
Thank you very much, and thanks again for the opportunity. Nice to talk to you.
Yeah, anytime, and I look forward to it in person, hopefully. Cheers, Lorenzo.
Cheers. Bye-bye.